Have you ever had like a quiet conversation with yourself about a substance? You know the exact moment I mean.
Oh, yeah. Everyone has those moments.
Right. You're standing in the kitchen after a really brutal Tuesday, maybe pouring that third glass of wine, or you're looking at a prescription bottle that's been lingering, a few weeks too long after a surgery.
Exactly. It's just this fleeting, completely silent thought where you pause and wonder, like, is this becoming a bit much?
Yeah.
Yeah.
Yeah, and it's a
Hmm.
deeply private question,
Ah.
but usually we just brush it off incredibly fast because, well, the cultural narrative immediately threatens us with these extreme
Well,
labels.
absolutely. We're taught that if you even have to ask the question, you must be in total denial.
Right. And that your only option is to, like, pack a bag, leave your entire life behind, and check into some 30-day rehab facility. But today we are going completely off that script.
We really are.
We're doing a deep dive into a clinical brief from Coping and Healing Counseling. They're a telehealth therapy practice based in Georgia, often called CHC. And we are going to completely reframe how we think about substance use recovery.
It's a much needed reframe, honestly.
Okay, let's unpack this because the very first data point in this brief reveals a shocker that just destroys that whole Hollywood narrative.
Yeah.
Most adults who meaningfully change their substance use do not go to rehab.
Yeah, that data point fundamentally rewrites the rules of engagement, I mean, completely. When we look at epidemiological studies of addiction and recovery, the vast majority of people who successfully alter their relationship with a substance, they do so outside the walls of an inpatient facility.
Wait, really? The vast majority?
Yes, at the vast majority. They rely on entirely different engines of change. So the primary drivers are actually targeted lifestyle adjustments, therapy-led behavior change, and self-directed reduction. And all of that is bolstered by strong social support. I mean, rehab, specifically that inpatient 30-day model, it's a vital, life-saving intervention for severe physiological dependence.
Right, of course. We're not saying it doesn't work for those who need it.
Exactly. But it has totally monopolized the cultural concept of recovery. And that leaves the massive, highly populated middle spectrum of users feeling like they have, well, absolutely no options.
Yeah, that black and white picture just completely fails to capture the reality of human behavior. If the only choices are ignore the problem entirely or blow up your life to go to an intensive facility, I mean, most people are going to choose to ignore the problem.
The friction is just simply too high.
Yeah, exactly. So if we break that monopoly, the immediate question is how people in that middle spectrum are actually achieving change. And the sources point to a concept that I think is going to challenge a lot of preconceived notions. It's a clinical framework called moderation management.
Yeah, moderation management is a heavily evidence-supported clinical goal, and it represents a massive paradigm shift in the field.
Because it's not just quit cold turkey.
Right. For decades, the addiction treatment industry operated on this strict abstinence-only mandate. The prevailing theory was that, any engagement with the substance was a total failure.
Which sounds so exhausting.
It is. Now, to be incredibly clear, the CHC brief explicitly notes that abstinence is absolutely still the correct and necessary goal for some individuals, especially those with severe use disorders or specific medical vulnerability.
Great, yeah.
But enforcing abstinence as the only acceptable goal for everyone actually drives people away from seeking help. Moderation management works by teaching individuals to track their triggers, establish really firm, predetermined limits, and practice mindful consumption. What's fascinating here is the neurobiological and psychological data surrounding this approach. When clinicians match a patient's treatment model to their actual personal preference, it dramatically improves both early engagement and long-term outcomes.
Okay, I have to be honest, I need to push back slightly here.
Go for it.
Because giving someone who already struggles with alcohol or pills the green light to just, moderate, it sounds like a massive recipe for disaster. Society is so deeply ingrained in that abstinence-only model that my immediate reaction is just pure skepticism.
That's a super common reaction, actually.
Right. Like, how does a clinician actually prevent that patient from just spiraling while hiding behind the excuse of moderation management?
Well, the clinical safeguard is the data tracking itself, combined with the mitigation of what we call psychological reactance.
Psychological reactor.
Yeah, it's a well-documented phenomenon where humans actively rebel when they feel their autonomy is being stripped away. If a patient with a mild to moderate use issue is mandated to commit to lifelong abstinence on, like, day one of therapy, their brain often fixates entirely on the restriction.
Oh, I see. Like telling someone they can never eat chocolate again.
Exactly. And that often leads to immediate relapse. Moderation management isn't a free pass at all. It is a highly structured, data-driven protocol.
So they have rules.
Strict rules. The clinician and patient work together to define parameters. For example, a maximum of 3 drinks a week, never on consecutive days, and absolutely never when experiencing a negative emotion.
Wow. Okay. That's very specific.
And the patient has to actively track this. If they continuously fail to maintain those parameters, the empirical data they gathered themselves proves that moderation isn't viable.
Ah, so they see it in black and white.
Exactly. They arrive at the conclusion that abstinence is necessary through their own lived data rather than having it dictated to them by some authority figure.
That is so powerful. It's the difference between self-discovery and getting a lecture.
Mhm.
It's like thinking the only way to get in shape is a punishing extreme boot camp where someone screams at you while you flip giant tractor tires.
Right, the classic boot camp.
Yeah. If you tell someone that's the only valid way to be healthy, they just won't do anything at all. They'll sit on the couch. When actually going for a daily sustainable 3-mile walk is the answer for most people.
That's a perfect analogy.
The tire flipping boot camp is the intensive rehab model. It works wonders for the people who truly need that level of structure and physiological intervention. But forcing the person who just needs to walk 3 miles a day into that boot camp is actively counterproductive.
Which perfectly sets up the crucial pivot in the CHC philosophy. Because whether the eventual goal is moderation or total abstinence, the mechanics of how a therapist actually fixes the underlying problem, they're the same.
Okay, how so?
Well, to create lasting change, the clinician has to temporarily stop looking at the substance and focus intently on the job the substance was hired to do.
The substance is an employee.
Think of it exactly like an employee. Substances are virtually never consumed in a vacuum. A person hires alcohol or hires a prescription painkiller to execute a highly specific necessary function in their daily life.
Like what kind of function?
They hire it to quiet acute social anxiety, to dull the sharp edges of severe depression, to numb the intrusive memories of a past trauma, or, to act as a dam holding back immense grief.
Oh, wow. Here's where it gets really interesting. Treating the substance use without addressing that underlying trauma or depression is like putting a bucket under a leaky pipe and calling it plumbing.
Yes. You're just managing the mess.
Right, you're managing the immediate mess on the floor, sure, but the pipe is still completely broken. You can empty that bucket all day long, but the water's just going to keep coming. The anxiety is still there, just screaming to be quieted. The grief is still demanding to be felt.
The clinical reality is that co-occurring mental health conditions are the rule, not the exception. The brief notes that it is exceedingly rare to encounter a substance use disorder that isn't tethered to a significant mental health burden, like anxiety, ADHD, or depression.
So treating them separately doesn't work.
Not really. Treating them sequentially, like sending a patient to a substance counselor for 6 months and then referring them to a psychiatrist for their depression way later, historically yields pretty poor results.
Because they're connected.
Deeply connected. The neurological pathways of the depression and the addiction are completely intertwined. Simultaneous treatment of both the substance use and the co-occurring condition is the gold standard for producing long-term behavioral change.
And the clinicians at Coping and Healing Counseling, they're specifically utilizing targeted therapies for this exact intersection. The brief mentions 2 major frameworks, motivational interviewing, or MI, and cognitive behavioral therapy for substance use disorders, which is CBT-SUD.
Yes, those are the heavy hitters.
MI is essentially the clinical art of resolving ambivalence, right? Instead of the therapist telling the patient why they need to change, the therapist uses highly specific questioning techniques to get the patient to articulate their own reasons for wanting change.
You nailed it.
It pulls the motivation from the inside out.
The mechanism of motivational interviewing relies on the simple fact that people are much more likely to be persuaded by what they hear themselves say than by what someone else tells them.
That is so true.
And once MI establishes that internal drive, the clinician deploys CBT-SUD to do the mechanical rewiring. Cognitive behavioral therapy operates on the ABC model, the activating event, the belief about that event, and the consequence.
Okay, give me an example of that.
Let's say the activating event is a really stressful meeting at work. The ingrained belief is, I cannot calm down unless I have a pill. And the consequence is, using the substance.
Got it. So where does the therapy come in?
CBT-SUD actively hunts down those cognitive distortions like catastrophizing, or all-or-nothing thinking, and completely dismantles them. The therapist teaches the patient how to intercept the thought pattern right between the activating event and the belief, fundamentally rewiring that neurological loop that leads to the substance.
It's a completely holistic, mechanical view of human behavior. And understanding this, understanding that the patient is just trying to manage a leaky pipe with the only tool they currently have, it completely changes the emotional landscape of recovery.
It really does.
It shifts the cultural conversation entirely away from moral judgment.
If we connect this to the bigger picture, we hit upon the most critical dynamic in addiction psychology. Shame fuels substance use, and compassion fuels change.
Say that again. Shame fuels use.
Yes. Shame is not just an emotion, it is a physiological state. It actually drives the nervous system into a chronic fight-or-flight response, spiking your cortisol and creating deep psychological isolation.
Oh, man.
When a person is trapped in that cycle of shame, they actually require more of the substance to soothe the heightened distress that the shame itself created.
So they aren't in a state of cartoonish denial, and they aren't morally weak. They are fighting a literal war on two fronts.
Exactly.
They are battling the internal pain that required the substance in the first place, and they are battling the crushing societal shame of needing it. A clinician who can hold that entire picture without an ounce of judgment. Someone who can look at the patient and say, I see the immense pain you've been managing, and I'm not going to judge you for the tools you've used to survive it. Let's just find better tools. That is the catalyst for real change.
That is beautifully said. But that level of clinical compassion is only effective if it is matched with actual logistical accessibility.
Right, because if you can't get to the therapist, it doesn't matter.
Exactly. The traditional 30-day inpatient model inherently creates massive structural friction. It often requires someone to take a leave of absence from their job, explain their disappearance to their social circle, and remove themselves entirely from their daily support system.
Which is impossible for a lot of people.
For someone whose substance use is mild to moderate, that level of disruption is just a complete barrier to entry. This is where telehealth models, specifically the one built by CHC, represent a vital systemic solution.
Yeah, coping and healing counseling is a 100% telehealth IPA compliant practice, serving all 159 counties in Georgia. We often talk about the psychological barriers to getting help, but the systemic red tape is just as formidable.
Oh, absolutely.
Whether you live in downtown Atlanta or a deeply rural county where mental health resources are essentially non-existent, the geographic barrier is completely erased. And they aren't just a tiny operation, right? They have a diverse, culturally competent team of over 15 licensed therapists.
The diversity of licensure there is really critical. They employ licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
So they cover a lot of ground.
Yeah, it allows them to handle individual therapy, couples counseling, family systems, and teen therapy for ages 13 and up. Because substance use never happens in isolation.
Right.
It ripples through the marriage, the parenting dynamics, and the broader family system. Having a team equipped to address those intersecting facets ensures the underlying environment is healed, not just the individual.
But the ultimate friction point, the reason most people never even attempt to get help, is the cost. Private therapy has a notorious reputation for being prohibitively expensive.
It does.
And most private practitioners don't even take commercial insurance because of the administrative nightmare. But CHC specifically designed their model to integrate with the major players. They take Aetna, Cigna, Blue Cross, Blue Shield, United Healthcare, and Humana, which brings session costs down to a range of $0 to $40.
That's huge.
And for Medicaid patients, there is a strict $0 copay.
By systematically dismantling the financial and geographic barriers, the only remaining hurdle is the patient's own readiness to engage.
And that brings us back to you, the listener. Let's put ourselves in the shoes of that person having the quiet conversation in the kitchen. Even knowing that affordable, highly clinical telehealth exists across the entire state of Georgia. Well, even knowing you could just call 404-832-0102 to reach a compassionate professional, picking up the phone to make that first call can still feel like trying to move a mountain.
The shame is heavy. It really is.
It is. So what does this all mean for the person who simply isn't ready to speak to another human being yet? Like, how do they bridge the gap from a siren question to clinical action?
Well, the clinical brief details the ultimate low-barrier entry point for exactly this scenario. CHC built a free 2-minute substance use store, use screening directly into their website at shoutouttherapy.com for mental health tests.
And it's totally private.
The brilliance of this tool is its absolute privacy. It doesn't require an email address, a name, or an account creation. It simply provides immediate, objective data using validated medical formats, specifically the DAST and ODAC questionnaires.
Yeah, the Odyssey isn't just a superficial internet quiz asking, do you drink a lot? It's a highly calibrated diagnostic tool.
Very highly calibrated.
It mathematically scores your consumption patterns, measuring frequency, typical quantity, and binge intervals, all to flag physiological risks that you might be completely blind to.
The math behind the ODAC and the DAST is what dictates the clinical pathway. This ties everything we've discussed today together. If a user takes that private 2-minute test and the data reveals severe physiological dependence, the clinical indicators strongly point toward abstinence and potentially more intensive intervention because the brain chemistry simply won't allow for moderation.
Okay, that makes sense.
But if the test yields a mild to moderate score, that data opens up the pathway for moderation management and outpatient therapy. It gives the user a quiet, completely low-stakes way to find out exactly where they stand based on hard science before they ever have to utter a single word to another person.
It is the ultimate first step for someone who wants to peek at the plumbing but isn't quite ready to call the plumber. Let's recap what we've uncovered today, because this is a profoundly empowering shift in perspective.
It really is.
If you are having those quiet conversations with yourself, you need to know that the binary is a myth. You do not have to choose between blowing up your life for a 30-day rehab facility or denying that a problem exists entirely. There is vast evidence-based middle path.
Exactly. You have options.
You can utilize targeted therapy to rewire your habits without leaving your home. You can explore moderation as a valid, clinically supported goal. You can find highly trained professionals who understand that your substance is simply an employee doing a job to mask anxiety, depression, or trauma.
They will help you fix the leaky pipe instead of just handing you a bigger bucket.
Yes. And whether you are in Georgia utilizing CHC's telehealth network or seeking resources in your own state, you absolutely do not have to walk this path alone, and you certainly do not have to carry the weight of shame.
This raises an important question, though, a thought to leave you with as you go about the rest of your week. We've spent this entire deep dive examining how substances, whether it's alcohol, prescription pills, or anything else, are usually just hired to do the job of masking underlying pain, trauma, or anxiety.
Right.
But if we accept that premise regarding substances, what other seemingly normal, completely everyday habits in your own life have you secretly hired to do that exact same job?
Oh, wow. Is it the endless, numbing scroll on your phone before bed? Is it the constant overworking, the obsession with being relentlessly busy so you never have to sit quietly with your own thoughts? Are those just different employees hired for the exact same underlying job?
It's definitely something to think about.
The picture of our habits is rarely as simple as we want it to be. But once you stop looking at the mess on the floor and finally start looking for the broken pipe, well, that's when the real healing begins.